Good day, everyone. I am Dr. Arik Paolo Delacruz. I am a ENT consultant and I am an assistant professor too at the West Visayas State University College of Medicine. So today, we're going to talk about anatomy of the head and neck region. So here are my references. First is Snell Clinical Anatomy by Richard Snell, Skandalakis, Surgical Anatomy by John E. Skandalakis, and Aesthetic Plastic Surgery of the East Asian Face by Hongril Jin, a very prominent Korean surgeon. I also got the Anatomy Atlas through zygotebody.com. It is a free online anatomical atlas which you can actually sign up, and it's totally free. It's really good. So an example for this is this one. Okay, so you can actually go to the website and you can browse through the anatomy by layers. You can rotate the model. Okay, you can even type. There's a search box that you can even type, like for example parotid gland, so it's there, right? So yeah, it's a really good resource for learning anatomy at home. And I also got various images from the internet, so credits to the owners. These images are used in my lecture for educational purposes only. So thank you guys for your images. Many will learn with these images. So in this lecture, we will be doing some kind of a fantasy sequence so that hopefully the concepts will be retained more when we do this fantasy sequence, as you will see in the next slides. Okay, so just ride on and just do the fantasy sequence with me. Okay, so you are a young doctor. You just passed the physician licensure exam boards, and you are currently working under two senior doctors. So you are the junior doctor, and you'll be working with them or under them as a young apprentice. Okay, so you check your schedule for the day to your phone, and your schedule for the day looks something like this. So 8 a.m. you have a Botox injection at a aesthetic center. 10 a.m. you have a outpatient clinic and probably seeing some outpatient cases. And at 1 p.m. you will have a scheduled surgery with your senior doctors, and the scheduled surgery is a thyroidectomy with neck dissection. Okay, so yeah, let's start the fantasy sequence. So you get dressed and off you go to work. Okay, so 8 a.m. you arrive at the aesthetic centers, and senior doctor tells you to do Botox injection on some patients. So the patient is Ma'am Evelyn, a 59-year-old female who came in because of rhytids or wrinkles. Okay, so she wants to have the rhytids injected with Botox so she can look a lot younger on Instagram. So people nowadays are a little bit more self-conscious because of social media. So probably this is the reason that Ma'am Evelyn came to you for Botox injection. So let's talk first a little about rhytids and Botox. So as we age, our skin tends to be thinner over time, and whenever we have facial expressions, the muscle that pulls the skin, it tends to wrinkle the skin, and well, it is more prominent when we are aging because our skin is more thinner. It's just like pulling a very thin cloth and pulling a thick cloth. So there's a tendency that the thinner cloth is more wrinkled than the thicker cloth. Okay, so rhytids are skin creases or wrinkles in the face. These are produced by the static pull of facial muscles on the skin, and this will produce the typical wrinkles that we have, like crow's feet, figure 11, frown lines, etc., as you will see later. So Botox is a medicine that is injected to the muscles. Okay, so Botox is actually a brand, no? It is produced by the company Allergan. So it became a household name when other companies produce the same medicine. Okay, so Botox is actually a synthetic toxin made from Clostridium botulinum, and this toxin will paralyze the muscle through prevention of the release of acetylcholine at the neuromuscular junction, resulting into paralysis. So when you paralyze the muscle in an aging person in a very strategic way, then that muscle won't crease the skin. That's the principle behind Botox injection. Okay, so there are typical points in the face or muscles in the face that we need to target so that we can relieve the wrinkles. So here in this slide, these are the skin creases produced by the pull of the muscles, and in this figure, these are the muscles itself which produce such creases. So we have the facial muscles. The facial muscles are also known as the muscles of facial expression. So we will learn that here. Again, when these muscles pull on the skin, they will produce some wrinkles. Just like this curtain, when pulled downward by gravity, there will be some creases. So that's the principle behind wrinkles. These facial muscles are innervated by the facial nerve, as we see here in the diagram. Okay, almost all the facial muscles are innervated by the cranial nerve 7. So the cranial nerve 7 exits from the brainstem through the stylomastoid foramen, just behind and underneath the ear. Then it goes forward, passes through the parotid gland, and divides into several divisions and branches. So we have two. Typically, there are two divisions, the upper division and the lower division. The upper division typically comprises of the temporal branch, which innervates the upper facial muscles and also the muscles near the eyebrow. And the lower branch is the zygomatic branch, which typically innervates the muscles of the cheek, and the nose, and the upper lips. The lower division, on the other hand, has three branches. The buccal branch, which usually innervates the lower cheek and also the lower lip. We also have the mandibular branch, which innervates the chin, and the cervical branch, which innervate the muscles in the neck. So these are the branches of the facial nerve. So let's go now to the individual muscles. So in this case, we have this guy. Look at the wrinkles on his forehead. These wrinkles are produced by the action of the frontalis muscle. We have two. We have left and the right. And notice that the frontalis muscle is absent in the middle. That's why skin creases sometimes are not present here. So it's more prominent here. So these are what we call the frown lines, and again, these are produced by the frontalis muscle. The frontalis muscle raises the eyebrow. So after Botox, if you target and paralyze the frontalis muscle, you notice that there is an improvement of the wrinkles of the forehead. Now let's go now to another set of muscles in the forehead. These are what we call the glabellar frown lines. Okay, the glabella is around here in between the eyes. So these are the glabellar frown lines, or sometimes we call it the figure 11 because it produces the 11 over here, the 11 line. So this creasing is caused by the action of the procerus muscle. This is the procerus. Okay, when this contracts, it will lower the medial eyebrow and produce the creasing. And also the corrugator supercilii muscles. Corrugator supercilii muscles are this one, are the triangular muscles on the lateral end of the procerus. When it contracts, it will make the medial side of the eyebrow meet together. So when doing Botox here, you will see there's improvement over here. Okay, so the blue arrows are the corrugator supercilii, and the yellow arrow is the procerus. Okay, next is the muscles that surrounds our eye. This is what we call the orbicularis oculi. If you notice that the orbicularis oculi is a circular muscle, it has an insertion and origin typically at the same place at the medial palpebral ligament. So when it contracts and shortens, it will make the eyes squint. But not only the eyes that squint, but also the skin surrounding the eyes also folds. So this is what we call the crow's feet. Okay, it looks like a crow's feet, no? And this is produced by the orbicularis oculi muscle. Okay, so this is a crow's feet. When we do Botox injection around the orbicularis oris, we lessen the action of the orbicularis oculi, and thus the crow's feet improves. Now, when we inject Botox in the orbicularis oculi, we inject it on the lateral side, so that this is where usually the crow's feet is found. However, we should be cautious of injecting over this area. Why? Because just underneath it, we can find the smiling muscles. Okay, these are the smiling muscles. These muscles will pull the lips upward and makes us smile, no? These are the zygomaticus minor and zygomaticus major. This is the minor, which is a smaller muscle, and this is a zygomaticus major. These two will pull the mouth or the lips upward, and thus producing a smile, just like this one, no? It will pull it upward. Now, the zygomaticus minor and the major, they insert into the corner of the lips or the mouth, wherein some muscles also insert. So the movement of the mouth is actually a concert of many actions of the several muscles of the face. This area where several muscles of the face insert is called the modulus, and some muscles that inserts also into the modulus includes the levator, labii superioris. So levator means it elevates. Labia or lips means lips, and superioris is it raises, no, upward. And also the levator anguli oris, no? So levator, it raises the angle of the mouth. Oris is mouth. We also have another muscle that makes our mouth go sideways, and it is called the rhizorius. Okay, so rhizorius that way. And also the buccinator, which is a little bit deeper than the rhizorius. And downward, we have the dau, or the depressor anguli oris. So if you notice, we have the levator, which elevates the modulus, and So we also have the depressor anguli oris, or the DAO. And we also have the depressor labii inferioris. Okay, this one. This depresses the lips inferiorly. Now, some doctors who inject Botox, they take advantage of the actions of several muscles into one area. For example, the brow. When we do eyebrow shaping, notice that the brow is both being moved by the frontalis and also by the orbicularis oculi. The frontalis will move the brow upward and the orbicularis oculi will move the brow downward. Now, if you paralyze the one that goes down, then the net action is it will raise the eyebrow because there's no opposing muscle that opposes the frontalis. That's how doctors will take advantage of the antagonistic actions of several muscle groups in the face. Now, take a look at this example. If you want your eyebrow to be a little bit higher, if you desire that, then doctors usually inject a couple of Botox here to paralyze the orbicularis oculi, and thus the frontalis will take command more, so resulting into a lift of the eyebrow. Let's talk about bunny lines. Okay, bunny lines are those found in the nose. These are wrinkles that are found in the nose, and these bunny lines are produced by the actions of the levator labii superioris alicanasi, okay, or LLSAN, and also the nasalis muscle. So the nasalis muscle is a muscle that surrounds the nose, and the levator labii superioris alicanasi is a muscle that is connecting the lips and also the nasal bridge. So both of them will produce the wrinkle in our nose. Now, to minimize or to get rid of the bunny lines, we tend to paralyze these two muscles. Let's go now to a gummy smile. What is a gummy smile? These are smiles that show a little bit more of the gums. Probably in this picture, the muscle tends to pull a little bit more upward than this one. So in order to treat a gummy smile, you have to paralyze the muscle that pulls it up. And the muscle is still levator labii superioris alicanasi, this one. So if you paralyze that one, it will droop down and it will hide the gums when smiling. Then we have the smoker's lines. So the smoker's lines is produced by the action of the orbicularis oris. The orbicularis oris is a circular muscle that surrounds our mouth. Okay, so when it contracts, it produces a wrinkle around the mouth. They call this the smoker's lines because probably smokers pout the mouth often and producing these lines over here. But of course, these are not per se caused by smokers, but it's just name for them to call this wrinkle. We have to inject some, not all of course, so that you will still be able to control your mouth around the orbicularis oris. So the orbicularis oris is also implicated in patients with cleft lip. Okay, so patients with cleft lip have inborn deformity of the orbicularis oris not being continuous to each other. The cleft lip babies usually have discontinuity over the lip in their orbicularis oris. So the orbicularis oris usually inserts together, but in cleft babies, this is deficient and it instead inserts into the nostril. So it pulls the nostril to the side, and this cleft side orbicularis oris will pull the ala on the other side, producing this deformity in babies, the cleft nose deformity. Sometimes you call it a cleft nose lip deformity. So surgeons will typically repair this one, not only the skin of the babies, but we have to connect the orbicularis oris together so that the babies will grow up with a patent orbicularis oris. Okay, not only the skin but also the muscles underneath. Then we have the marionette lines. What's a marionette? Marionette is a kind of a puppet, but the marionette type of puppet, they have this opening in the mouth so that they can actually control the mouth while doing puppet shows. So these are the marionette lines. So in patients, this is the marionette line, and the marionette line is a wrinkle produced by the muscle depressor anguli oris. So this is the depressor anguli oris. All right, it pulls the skin here downward and forward. Sometimes it is not enough to paralyze this one so that the depression is corrected, but we also treat it with a little filler. Example, this one, we put some hyaluronic acid over here, then compared to this one. So we put it so that the skin will also elevate. Not only it will produce the wrinkle, but it will also elevate, and the depression will be gone. Okay, so caution in injecting Botox in the depressor anguli oris. We don't inject it near the DLI. This is the DLI, the depressor levi inferioris, because once we inject that, this will become paralyzed and the patient won't be able to move the lips downward, and thus you will have an asymmetrical left and right when doing mouth movements. So these are very near to each other. Next is the cobblestone chin. Cobblestone, this is an example of a cobblestone street road made up of cobblestones. So some patients may have cobblestone chin. These are produced by the mentalis muscle, when the mentalis muscle will pull the skin of the chin upward and underneath. Okay, so upward and underneath. So it will wrinkle, just like this one. So some patients find it unattractive, thus they have it paralyzed. So we put some Botox over here so that it will be relieved. Now again, we have the mentalis in the middle. We have the DLI, or depressor levi inferioris, and the depressor anguli oris, or the DAO. So next, let's go now to the turkey gobbler neck. A turkey gobbler neck happens when a muscle in the neck will produce a very, very prominent creasing, just like these people when we get old. Okay, the muscle is very active, yet the skin is very loose. Okay, so turkey gobbler neck is also found in turkeys. They have this sagging skin in their necks, and these are also called platysmal bands. This turkey gobbler neck is produced by the platysma muscle. Okay, we have the platysma muscle, and we have this one here. It is also part of our facial expression, especially as we clench our teeth or express anger. Our platysma moves. So when we get old, our platysma will be more prominent and thus will produce this appearance. The platysma has a left and has a right side, and it reaches from the clavicles down to the sides of the face, over here. And these are the examples of the platysmal bands. So we just inject Botox on the very active platysma so that it will look better. Now, let's review all the facial muscles of expression to the zygote app. Okay, so we have here the zygote model. This is our model. Now, if you go remove the hair and remove the skin, so we have here the muscles in the face. So we have the frontalis muscle. Frontalis. Okay, so it inserts into the eyebrow. We have the procerus muscle. Okay, it's midline. It controls our skin in between the eyebrows. We have the corrugator supercilii. Okay, one side. We have the orbicularis oculi, controls the squinting of the eyes and also the lowering of the eyebrow. And we have here the nasalis. It produces the bunny lines. And here is the levator labii superioris alicanasi. It also contributes to the bunny lines as well as the gummy smile. Okay. Now we also have here the zygomaticus minor. This controls our smile, and the major, also another smiling muscle. We have here the risorius, which control the angle of the mouth sideways. Okay. Now we have here the orbicularis oris, which control the aperture of the mouth. Okay, and these are the muscles producing the smoker's lines and also the muscles implicated in the defect of cleft lip babies. Okay. Now going downwards, we have the depressor anguli oris. It depresses the angle. Okay, and this produces the marionette's lines. Now it has a counterpart, levator anguli oris. Okay, and the depressor. Now let's go a little bit more forward. We have the DLI or the depressor labii inferioris. It depresses the lips. No? We don't inject in this one. We inject on the DAO or the depressor anguli oris. Now we have the mentalis muscle. We have one here and one over here. Okay, this produces the cobblestone chin. And we have the platysma. So it comes from the clavicles and inserts into the angle of the mandible. Okay, so yeah, so that pretty much is the muscles of the face. So I hope you have correlated the popular procedure or Botox with our lesson. No? Next slide. 9:30 in the morning, we have a second patient in the aesthetic center. We have Anna, a 31-year-old female who came to you because she wants to have a V-shaped defined jaw. Okay, a lot of people right now in the social media wanted to have a V-shaped defined jaw, a V-shape. Okay, sometimes the Asian face is usually a round face. No, sometimes they describe it as a spoon face. So because of pop culture, we wanted to have a more V-shaped shape in our jaw, and Botox has a solution for that. Okay, this side of the face produce that roundness, and Botox injection to the masseter muscle here, corresponding to this one, will make our face more V-shaped. So compare before and after. The masseter is actually not a muscle of facial expression, but it is part of a group called the muscles of mastication or muscles for eating. So the muscles of mastication includes masseter, temporalis, medial pterygoid, and the lateral pterygoid. The first three are muscles which close the jaw, And the last one, the lateral pterygoid, is the only one that opens the jaw. Okay, so you see the discrepancy. You have 3 muscles to close it and only one muscle to open it. So these are the muscles of mastication. We have the masseter. Okay, it controls the jaw by inserting into the mandible. We also have the temporalis, a very big muscle that spans the temples. Okay, it's called the temporalis, and it inserts into the jaw this way here. Underneath, we have the medial pterygoids and the lateral pterygoids. Okay, these are the medial pterygoid. This also close the jaw, and the lateral pterygoid, this one is the one that slightly opens it. So we have what we call the 3 versus 1, 3 muscles that close the jaw and only 1 muscle that opens the jaw. So the 3 versus 1 is usually very prominent in clinical cases, no? Wherein when there is spasms of the muscles of mastication, when there is 3 versus 1, net action is to close. If everything here spasms, no, meaning it contracts, no, without your control, the net action is to close. Just like in the case of tetanus, no? When there is a tetanus infection, a toxin from the Clostridium tetani will have spasms of muscles, and it is more prominent in the muscles of mastication. So patients will have actually a locked jaw, so because the net action is to close, so you cannot open it because 3 muscles will close it, only 1 will open it, so we have the locked jaw. Let's go now to the zygote. Okay, so zygote, we have here, this is the masseter muscle. Okay, so on the side is very prominent, but in front it can also contribute if your muscle is a little bit big. Okay, which usually Asians have a really big masseter muscle. It will make our face a little more round. And we have the temporalis muscle. It's a big muscle that spans our temples and goes down and inserts into the jaw. And we have the pterygoids, no? Okay, we have the pterygoids. We're here. And another pterygoid is over here. Okay, it's where it's okay, you can't see them, but let's see if you can see them. Yeah, it's inside them. You see there. Okay. Okay, now let's go now to our next activity for the day as young doctors. So, which is at 10 a.m. we have to go to the medical clinic at Molo to see some outpatient patients. Okay, so when you arrive there, the nurses already inform you that you have 2 patients waiting. So the first one is a 14-year-old male with a pre-auricular mass left, meaning, so it's pre-auricular, meaning this is the auricle, it's here, pre-auricular mass left, there's a mass, this one. And we have the second patient is a 22-year-old female complaining of the stiff neck. Okay, so let's go first to our first patient. So the pre-auricular mass is a parotid mass. This patient is a 14-year-old male, presents with a 3-day history of progressive facial and neck swelling, and he was exposed to a mumps outbreak at school. So probably we will have a higher suspicion that this patient is a mumps patient. So mumps viral infection is actually an infection caused by mumps virus, which spreads through saliva, nasal secretions, and primarily affects the parotid glands. So the parotid glands is actually a set of glands which produces our saliva. Now let's talk about the salivary glands. Now the salivary glands, we have 3 of those. first is the parotid glands, the submandibular glands, and the sublingual glands. So in this picture, the parotid gland found in the pre-auricular area. The submandibular gland is found underneath this mandible. That's why we call it a submandibular gland. If you have to press on the concavity underneath your jaw, it is usually there. And we have the sublingual glands. By the term itself, it is underneath the lingua or the tongue, sublingual gland. All of these produce our saliva. So let's talk first about the parotid gland. So the parotid gland is the major salivary gland. It is found just anterior to the ear or in the angle of the jaw. It produces majority of stimulated saliva, meaning when we eat or when we have the stimulation of food, no, or the sight of food, no, this is what we call the stimulated saliva. The parotid gland produces saliva and it transports the saliva through the Stenson's duct. Okay, this is the Stenson's duct. The Stenson's duct carries the saliva inward into the mouth, piercing through the buccinator muscle. This is the buccinator muscle. So it pierces the buccinator muscle. And it drains through the buccal cavity. This is the buccal cavity. Opposite the second maxillary molar. So here, you can see it here. So the saliva is produced in the parotid, goes inside the mouth and drains into the buccal cavity. The second salivary gland is the submandibular gland. It is located below the floor of the mouth, more anterior to the angle of the jaw. So this is the angle of the jaw. It's more anterior. It's more anterior. Okay. It produces the majority of unstimulated saliva. So when we are at rest, no, we don't have the sight of food, or when we're not eating, just like when we're sleeping, no, the saliva that is produced is carried off by the submandibular gland. The submandibular gland also has a duct, no? We call it the Wharton's duct, and it courses underneath the mylohyoid muscle. This is the submandibular gland. This is the Wharton's duct. It courses to the mylohyoid muscle. The mylohyoid muscle is actually one of the muscles that forms the floor of the mouth. Our mouth has a floor, no? Dapat may floor yan. Otherwise, our tongue will just fall down. So this is the mylohyoid muscle. Just beneath that is the submandibular gland and the Wharton's duct. So the Wharton's duct drains through the floor of the mouth just beside the frenulum of the tongue. This is the frenulum of the tongue, the one that all of us has a frenulum. It's a structure midline. Just lateral to the frenulum are the openings of the Wharton's duct. In some babies, their frenulum is thick, no? Very thick. That's why they have what we call the tongue tie. No? A thick frenulum limits the movement of the tongue, especially when talking. No? Kasi we need the tongue to talk. So if you have a thick frenulum, probably you have a tongue tie. And the last are the sublingual glands. Okay, sublingual glands are saliva producing glands just underneath the tongue. Okay, these are minor salivary glands, and their ducts are called the ducts of Rivinus, which drains into the floor of the mouth. So these are the sublingual glands, and notice they have several ducts draining underneath the tongue, and these are the ducts of Rivinus. Compared to the submandibular gland and the parotid gland, they have multiple openings. Okay, so what do we do with the boy, with mumps? So usually mumps is a viral infection, and as such, viral infections are only managed with supportive measures, just like hydration, oral hygiene, pain control, and probably bed rest and isolation. And also, I need to underscore the importance of vaccination so that we won't get mumps. The mumps vaccine is available to babies at 12 to 15 months of age. Okay, so let's go now to our next patient at the outpatient clinic. So we have the stiff neck patient. So we have a 22-year-old female who woke up with a very deep aching pain and stiffness, more emphasized on neck movement. After her first time working out at home, muscle pain in the neck, or a myalgia to the neck, occurs when the muscles at the back of the neck becomes inflamed because of exertions, prolonged static loads, repetitive work, and poor position. So at this point, we need to know what are the muscles at the back of the neck versus muscles in the front of the neck. Okay, so because our patient here has a condition at the back of the neck. So neck, back versus front. So how do we know which is the back of the neck, which is the front of the neck? Which is posterior, which is anterior. So the guide here is the sternocleidomastoid muscle. Okay, so here we have a picture sideways. This is the sternocleidomastoid muscle. So this muscle connects the mastoid bone. Okay, this is the mastoid bone. And it connects the sternum and the clavicle. So as you can see, 1 and 2. So the sternocleidomastoid muscle has two bellies. We have the first belly that connects the sternum and the mastoid, and also another belly that connects the clavicle and the mastoid. So that's why it is called the sternocleido. Cleido means clavicle and mastoid. So SEM for short. So we will encounter the SEM more often in the next slide. So take note of it. So anyway, so in order to delineate which is the back of the neck and the front of the neck, we have the SEM. So when we draw a line from the mastoid into the sternum, anything that is at the back of this line is posterior, and anything in front is anterior. Some regard that the sternocleidomastoid is part of the posterior. Yeah, I believe so. This is part of the posterior. Now, the sternocleidomastoid muscle is a very big muscle here. Actually see it. And it functions to rotate the head to the opposite side. So it moves over here, and the one that moves over here. Just like this guy, no, when he moves his head on the other side. The sternocleidomastoid is the one that produces such action. Now, if you put a line from the base of the skull and another line at the line of the sternum and another line from the mastoid and this muscle, this back muscle, which we call the trapezius, and another line in the middle of the neck, we will produce two triangles. No? This triangle and this triangle. This is the anterior triangle, and this is the posterior triangle. Now, let's talk about torticollis. Torticollis is a pathology of the sternocleidomastoid muscle. When your sternocleidomastoid muscle becomes so hypertrophic, no, it's so enlarged on one side and the other one is weak, so there will be net movement of head on one side. Or when you have a very small one or absent sternocleidomastoid on one side and you have a normal one on the one side, then that side will actually move the head on one side. Just like in these cases, no? Congenital torticollis and acquired torticollis. Okay, this one very prominent on one side, so it moves the head on one side, and usually patient is stuck on one side. And this baby, because of the absence of sternocleidomastoid on one side, then the head, he was born with a head, abnormally turned in one side. Now, let's discuss now the muscles at the back of the neck. So we have the sternocleidomastoid muscle, which we have already discussed. Next is the trapezius, this one. We have the anterior, middle, and posterior scalenes. It is deeper in both. And we have the semi-spinalis capitis and the splenius capitis muscles. The capitis means head, capitate, decapitate, no, capitate is head. And these two muscles are found near the head at the back here, which we will show later. So first, let's talk about the trapezius, popularly known as the traps. No? This is the colloquial word for the trapezius, traps. You will see this here. This is a big muscle that spans the back of the neck. And it is not only in the neck, but it also spans in the shoulders and into the back. Now we have the left and the right trapezius. Both of them will form a diamond-shaped muscle. No? So in this figure, you will see that it is inserting into the back of the head, the shoulders, and the lower back. So the function of it supports our head. Right, one. Otherwise, your head will fall off forward, and also your shoulders. No? Okay, and also the back, so that the back won't arch forward. So some people have a very well-developed traps, just like bodybuilders. See this one? These are the traps. And not only it is more seen, no, or more obvious in the back, but some bodybuilders want to have a very well-developed traps so that they may have a good shape when being looked in the front. Okay, this one. So again, the function of the trapezius is to maintain head posture and also to do shrugging and also arch the back. Now, as such, bodybuilders will develop this one by doing shrugs. Okay, this one with a weighted object. Next are the scalenes. We have the anterior scalene, the middle scalene, and the posterior scalenes. So if we have to remove the trapezius out and the sternocleidomastoid muscle out, we will be left with the scalenes, no? Anterior, middle, and the posterior. So notice that the anterior and the middle, there is a gap in between. Then the middle and the posterior, there's a gap here. There's a reason for that, because this is where the space for the subclavian artery and the brachial plexus to exit the neck. It's like this one, no? The scalene anterior and the scalene middle scalenes, no? In between, we have the brachial plexus, a network of nerves which go into our arms, and also the subclavian artery. So let's go now to the semi-spinalis capitis and the splenius capitis. This is found more at the back near the head. We have here the splenius capitis and the semi-spinalis capitis. No? It is more deeper than the splenius capitis, and these function to hold the head in place also the flex on one side and the other. Now, how do we manage these girls' acute neck pain? Usually, we advise them to do massage, physical therapy, and do some pharmacologic management such as paracetamol and other NSAID or non-steroidal anti-inflammatory drugs, no? Which may include mefenamic acid, ibuprofen, naproxen, diclofenac, etc. So these are what we call NSAIDs. Let's go now to our zygote to take a look at the back muscles. So we have here the muscles. So this is the sternocleidomastoid muscle. We have one on both sides. No? Okay. Now here we have the trapezius. No? So notice that this is a diamond shape muscle. Spans from the head, shoulders, into the lower back. Okay, now we have here, the splenius capitis, it goes to the side. And we have here the Semi-spinalis capitis. Okay. And now we'll go now to identify the scalene muscles. So in order to identify that, we have to find the subclavian artery and the brachial plexus. These are found here. Probably this is the anterior scalene. Okay. So anterior scalene, these are the brachial plexus. Okay, goes into the arm and the subclavian artery. So this will be exiting between the anterior scalenes and the middle scalene. So this is the middle scalene, this is the anterior scalene. And at the back of the middle scalenes are the posterior scalenes. Yeah, so we have to thank the zygote ready for that. Okay, so you can actually try it after this lecture. It's really nice, and it's very helpful in your home study. So next in the schedule is 2 p.m. at the WVSU-Hospital. So notice that you are 1 hour late of the schedule, but that's okay. I mean, it happens, no? Probably there's traffic, or the patient has some pre-op necessities to do. The surgical resident brief you on the case before the procedure. So he says, this is a case of a 70-year-old male who presented with a 5-year history of a left anterior neck mass and a 3 months history of enlarged lymph nodes left and right. Okay, there's also one on the right. A needle biopsy was done on the said mass, revealed thyroid cancer. Okay, so this is thyroid cancer, and probably these are lymph nodes. So the surgical plan for this patient is a total thyroidectomy, which means we have to remove the thyroid totally, and also the neck mass, which is in the form of a procedure called neck dissection. Okay, so what is thyroidectomy? So thyroidectomy is a procedure wherein we have to remove the thyroid because of cancer. So papillary thyroid cancer, or PTC, is the most common thyroid cancer. So this is the thyroid gland. So if you have a tumor over here, it usually spreads or metastasizes through the lymph nodes of the neck. So we have several lymph nodes on the neck. It usually spreads there. So in this patient, it spreads through here and it enlarged. And treatment of choice for thyroid cancer is a total thyroidectomy, which means we have to get the left thyroid and also the right thyroid. Okay. Of course, this is really advanced for your level, but just play along. A total thyroidectomy is usually followed by removal of the neck nodes, because this way you will treat the patient more. You will treat all the primary tumor and also the neck nodes wherein the tumor has spread. So to do this, we need to open the muscles of the anterior neck. The thyroid is situated deep into the neck. It is covered by the anterior neck muscles, such as all of this one. Reach the thyroid gland, remove it safely from the surrounding structures like the laryngeal nerves, the parathyroid glands, the carotid vessels, the trachea, and the esophagus, and also remove all the neck nodes. Okay, so this is where thyroidectomy is a very challenging procedure, because you remove the thyroid in a safe way so that it won't damage all the surrounding structures around the thyroid gland. So yeah, so let's discuss bit by bit. So we already discussed muscles in the back of the neck. Now we'll first talk about the muscles in the anterior neck. Anterior neck muscles, we have the platysma. We have already discussed that as the Botox case. We have the strap muscles, okay, platysma, and the strap muscles. So platysma goes before the strap muscles. So platysma is the most superficial, and these are the strap muscles. So now let's discuss the strap muscles. Here are the pictures of the strap muscles. So the strap muscles are composed of 4 muscles. First is the sternohyoid, meaning it spans from the sternum to the hyoid. This is the hyoid bone, and this is the sternum. So it spans the whole anterior neck from the hyoid to the sternum. As such, it is called sternohyoid. Next is the omohyoid. Omohyoid is a very unique muscle wherein it comes from the hyoid bone, and it goes down and it goes sideways. Okay, that's the only strap muscle that goes sideways. And we have the thyrohyoid. It is a muscle that spans the hyoid and the thyroid cartilage. The thyroid cartilage is over here. In this picture, we have it, the pink one or the red one. And on the side, it's here. And lastly, we have the sternothyroid. So from the sternum to the thyroid cartilage. So these are the strap muscles. Now notice we have the strap muscles on both sides. We have 4 sets on one side and 4 sets on the other side. These are joined in the midline. There is a tissue that holds them in the midline, as we'll see later. Now notice that the strap muscles are what we call the infrahyoid muscle, meaning infra means below the hyoid. This is the hyoid bone, because there are muscles above the hyoid, which we call the suprahyoid muscles. So the strap muscles are the infrahyoid muscles. So what's between the suprahyoid muscles and the infrahyoid muscles? Of course, the hyoid bone. So let's first talk about the suprahyoid muscles. So supra is above the hyoid bone. So we have the geniohyoid, okay, from the middle of the mandible to the hyoid bone is the geniohyoid, and we have the mylohyoid. It's also the floor of the mouth, as discussed earlier in the submandibular gland, denoted by the pink red one. We have the stylohyoid, a muscle that spans the hyoid and the styloid process. And we have the digastric. The digastric is a V-shaped muscle. Okay, we have 2 bellies. We have the anterior and the posterior belly, denoted by the green muscle in the figure. So we have 4 also. In the infrahyoid, we have 4 also. To the suprahyoid muscles, which are the mylohyoid, geniohyoid, stylohyoid, and digastrix. The mylohyoid and the geniohyoid forms what we call the floor of the mouth. No? It support the mouth and the tongue. Also, the digastrix, in a way, support the floor of the mouth. So suffice it to say that the suprahyoid muscles are made to support the mouth. Okay, this is the mouth. So if you press on that and press over here, then you will feel the suprahyoid muscles. Now let's talk about the hyoid bone, going downward. So we have here the hyoid bone. Hyoid bone is a floating bone. It doesn't have any connections to other bones. It's just a floating bone. And I like to call it a suspension bone because it is suspended by the muscles above and muscles below. So the muscles above and the muscles below will put attention, and thus it just floats. Just like this one. This is a suspension bar. It is supported above and supported below. It's just like the suprahyoid and the infrahyoid muscle. That is a suspension bar. So the hyoid bone not only supports the suprahyoid muscles and the infrahyoid muscles, but it also determines our cervical-mental angle. Cervical means neck, mental is the below the chin. So this is the mental, and this is the neck. So we will have an angle. The point where the below the chin and the neck meets, that's usually where our hyoid is found. Okay, so in this figure, this is where the hyoid is. This is the submental area, and this is the neck area. So we have an angle there, and we have an angle here. So the hyoid bone is the one that pulls the muscles of the suprahyoid and the infrahyoid muscles, so that we will have that angle. Now, why is that angle important? Some of us have a very sharp angle, some are normal, and some doesn't have any angle at all. No? So in this, this came from a journal. So you notice that those who have a more broader neck, their position of the hyoid is different from those with a sharp neck angle. So going back to our patient, where is our hyoid? So it is where the submental area meets the neck. No? So it's about here. Okay, so notice that the mass is below the hyoid bone. So it must be affecting the infrahyoid area rather than the suprahyoid area. Now, we go now to our thyroidectomy. We already know our strap muscles, so we have to expose the thyroid to the strap muscles. So we have to open the strap muscles. Just have to retract, no, or to move the strap muscles, the left strap muscle and the right strap muscles. You just have to open it, just like this one. We have one set of strap muscles to the left, one strap of muscles to the right. It's like opening a curtain. No? Just open it. Okay, you don't have to cut it, you don't have to do anything, you just have to expose it, because it is joined midline by a thin fibrous tissue. We call it the median raft. There's a median raft over here, you just have to pull it sideways. Okay. It is an actual picture. So you have to, these are the strap muscles, and we just go midline. After we retracted the strap muscles to the side, the left strap muscles and the right strap muscles to the side, we will reach the thyroid gland. Okay, our gland of interest in this case, actually. So this is the thyroid gland. Okay, this one. Now, the thyroid gland is a butterfly-shaped gland. It is composed of the right thyroid gland and the left thyroid gland. Each of them is around 5 centimeters by 3 centimeters by 2 centimeters in dimension. So we have 5 by 3 and 2 centimeters in thickness. And we have what we call the isthmus. Isthmus is this one in the middle that bridges the right from the to the left. It is usually 1.3 centimeters wide, and sometimes we have the pyramidal lobe. It's in the middle. We don't have it here, but it is usually there. The thyroid gland produces thyroid hormones. No? So, the thyroid gland, anatomically, it hugs the cricoid and the trachea. So, this is the trachea, and this is the cricoid. This is the thyroid cartilage. Again, this is the hyoid. Going downwards, we have the thyroid cartilage. The next is the cricoid cartilage, and then the trachea. Hyoid, thyroid, cricoid cartilage, and tracheal cartilage. So the thyroid gland is found usually in the cricoid and the tracheal cartilage. It is not found in the tracheal cartilage. So a thyroid gland is not found in the thyroid cartilage. It is found lower the thyroid cartilage in the cricoid and tracheal cartilages. Now, the thyroid gland hugs the cricoid and tracheal cartilage like a koala. No? It hugs it. Okay? Or a clingy girlfriend. Now, why is this important? It's because it is hugging the trachea. Now, the trachea usually elevates when we swallow. You can see I'm a little thin. Okay, it goes up when you swallow. Now, since the thyroid gland is hugging the trachea, it also moves up, elevates when we swallow. So when you examine a patient with a thyroid abnormality, you tell them to swallow because you may be able to delineate if the mass is indeed a thyroid mass when it goes up when swallowing. The trachea elevates when swallowing, so the thyroid also elevates when swallowing. So that's a technique we do in examining our patients with thyroid tumors or masses. Once we reach the thyroid, we have to do thyroidectomy or cutting off the thyroid. We need to be careful with the following. First, of course, the arteries in the veins, we have to cut them safely. We also need to be careful of the nerves that surrounds the thyroid gland. The most important nerves that are found near the thyroid gland are the recurrent laryngeal nerves, RLN, and the external branch of the superior laryngeal nerve, or EBSLN. Two nerves. We'll discuss that in a while. We also need to be careful of the parathyroids. This is very near the thyroids, parathyroid glands. We also be careful to cut off the thyroid and be wary of the adjacent carotid sheath. We also be careful with the trachea and the esophagus, which is also near the thyroid gland. That's how surgeons work. We have to remove a gland, but we really have to be careful not to damage the other glands or tissues surrounding the target gland so that we won't have complications. First, we have to be careful with the 3 arteries of the thyroid. So we just don't remove the thyroid per se, but we have to clip off the arteries of the thyroid. So we have the superior thyroid artery, this one, the inferior thyroid artery, this one, and there is a third artery, we call it the thyroid ema artery. Thyroid ema artery. Superior, inferior, and the thyroid ema. We also have to be careful with the 3 veins of the thyroid. We have the superior thyroid vein, we have the middle thyroid vein, and we have the inferior thyroid vein. Notice that the vein has a middle part and the artery has no middle part. And the vein doesn't have the thyroid ema. Next, we have to be careful with the nerves. This is the most important part of the surgery of the thyroid. First is the recurrent laryngeal nerve. We have one on the left and one on the right. So if this is the thyroid, the left recurrent laryngeal nerve is this one. It goes down and goes up. It's very near the thyroid. The right, it goes down and it goes up. Now, these laryngeal nerves are found just at the back of the thyroid. Now, if this is the thyroid and we're looking at it at the back, so this is the front, this is the back. So the nerves are found at the back of the glands. So we just don't get the thyroid out blindly. We have to identify this one and separate it when doing thyroidectomy. Now, these 2 nerves are responsible for the control of our voice box or our voice. Now, if you are not careful and you cut it when you remove the thyroid, then the patient will have hoarseness. Usually, thyroidectomy doesn't result into hoarseness. Sometimes an urban myth. It's just how you identify structures and anatomy, then you will preserve the nerves when you get the thyroid out. Then, we have to be careful with the external branch of the superior laryngeal nerves. Again, we have 2 superior laryngeal nerves. So, this is in the yellow structure. So this is the external branch, and it goes down. This is the hyoid. This is the thyroid cartilage, and this is the cricoid cartilage. This is the tracheal cartilage. So the thyroid gland must be somewhere here, in the cricoid, in the tracheal. Now the external branch of the superior laryngeal nerves is around in this area, in the upper pole of the thyroid. It is located near the upper pole of each thyroid lobes. Okay, so when you get the thyroid out, be careful of this one. It actually functions to innervate the cricothyroid muscle. No? The cricothyroid muscle. So the cricothyroid muscle is the muscle that is responsible for the high pitch of our voice. The high pitch of our voice. Now, if you cut this when you do the thyroidectomy, then you cannot reach the high pitch voice. Loss will result to inability to reach high notes, as exemplified by this opera singer, Amelita Galli-Curci. Sometimes they call the nerve as the Galli-Curci nerve because of this opera singer. So she underwent thyroidectomy back in early 1900s, and after thyroidectomy, her career was ended because she wasn't able to reach high notes already, because probably the external branch of the superior laryngeal nerve was cut. So it's very important to identify this one, and whenever you think of the thyroid gland, you always think of the external branch of the superior laryngeal nerves. Next is we should be careful with the parathyroid glands. So the parathyroid glands are composed of 4 glands. We have 2 superior parathyroid glands and 2 inferior parathyroid glands. These are located at the back of the thyroid. So this is the thyroid when seen at the back. Parathyroid glands are seen over here. Superior, superior, inferior, inferior. So this is the butterfly-shaped thyroid. It is just at the back. So we have to separate it from the thyroid gland because it may become damaged if you get it without identifying it. So these glands secrete parathyroid hormone or PTH, which regulates calcium and phosphate metabolism of the body. Now, if you cut this one or if you damage it during the surgery, it will result to a hypocalcemia. So your body won't be able to regulate calcium, and you will have a low calcium level in your blood, or a hypocalcemia, which will result into cramps, muscle spasms, paresthesia, and nerve numbness. So very disastrous if you won't be able to identify. Sometimes you just need to preserve 1 or even 2, not all, no, but you have to preserve 1 parathyroid gland. In actual pictures, this is what the parathyroid looks like. This is the thyroid. This is at the back of the thyroid, as you can see. Next, we have to be careful with the carotid sheath when we extract the thyroid out. So this is a cross-sectional view of our neck. This is the skin. So these are the strap muscles I've discussed earlier. Though they meet at the midline, the median raphe, and we reach the thyroid. Okay, this is the trachea. Now the carotid sheath is a sheath on either side of the thyroid, which contains the carotid artery. This one, the carotid artery, indicated by the red drawing. Okay, this is the main artery to the brain and the head. So if you cut that, if you damage that, you will have less blood to the brain, and sometimes you get a stroke. We have 2 of them. We have the jugular vein. The jugular vein is more anterior and more superficial than the carotid artery. It is bigger, actually. It is indicated here in the blue drawing. And the vagus nerve. The yellow one is the vagus nerve. These are the contents of the carotid sheath. From medial to lateral, we have the carotid artery, the vagus nerve, and the jugular vein. The vagus nerve functions in many internal organs like digestion, heart rate, respiratory rate, etc. So just have to read on that. but it is very important in many bodily functions. So we have to be careful not to damage this one when we get the thyroid out. So in the cadaver, this is a very big one. This is the jugular vein, and the carotid artery is this one. The vagus nerve is not seen here. The jugular vein is also where the vampires tend to suck blood, no? In this area. Next, we need to be careful with the cervical trachea. Cervical meaning the neck trachea. So we have two parts of trachea. We have the cervical trachea and the thoracic trachea. The chest trachea and the neck trachea. The thyroid is found in the neck trachea or the cervical trachea. So this is the thyroid gland. This is the trachea. As discussed earlier, the thyroid gland hugs the trachea. So if we have to get the thyroid out, we just be careful not to damage the cervical trachea. So the trachea is identified by its corrugated structure. It has corrugations on it. So if you have to palpate it here, if you notice some corrugation, that's the trachea. It is just at the back of the thyroid, and yeah, we call it corrugated cartilage. It is midline, usually midline, but it can move. Depends on if you have a very big thyroid gland on one side, it will push the trachea to another side. It starts in the C6 vertebra. So this is the, again, hyoid is above, then this is the tracheal cartilage, the cricoid cartilage, and the trachea. The trachea starts at the C6 level. It is composed of 15 to 20 U-shaped, okay, it's not a complete ring, it's U-shaped rings of hyaline cartilage. And so if this is the U1, so it's like that one. At the back, it is united by a smooth muscle called the trachealis. Notice in this picture above, this is a U shape. At the back, there's no cartilage, but it is a smooth muscle. Now, if you damage it, for example, if you cut through it, when one breathes, air will leak out your neck, and you will have air pockets in your neck. We call it the subcutaneous emphysema. You will have air pockets. You can feel air here. There is a leak in the trachea. So, in order to avoid that, we need to know that the thyroid is just very intimate in front of the trachea. Next is we have to be careful with the cervical esophagus. The cervical esophagus is just at the back of the trachea. So this is the esophagus, trachea, esophagus at the back. It is a muscular tube which allows food to pass from the mouth into the stomach. It also starts at the same area of where the trachea starts now. It's around C5 to C6. At the level of the cricoid cartilage, again, thyroid cartilage, cricoid cartilage, and the tracheal cartilage. When you cut this one or you have damage to it while removing the thyroid, for example, you cut it over here, food will leak out into the neck. Okay, when you eat, or saliva will leak out, and it will cause deep neck infection. Okay, so we have to be very careful of the area surrounding the thyroid. So this is the, I know this is not your level, but just a correlate. When we do the thyroidectomy for our patient, we open the skin, we dissect the strap muscles out, remove the thyroid, we preserve the nerves, we preserve the trachea, and also the esophagus at the back. Now at this point, we'll go back to our zygote anatomy model. So we'll focus on the neck. So if you notice, we have this shadow. This is formed by the sternocleidomastoid muscle. So in between the two sternocleidomastoid muscles, the strap muscles should be found after the platysma. So if we go inwards, so this is the platysma. So we have to go through that and downward. Okay, so we have the sternocleidomastoid muscle. We have the strap muscles over here in between the sternocleidomastoid. So yeah, this is the omohyoid, the strap muscle which goes to the side. Okay, this is the sternohyoid, sternum and hyoid. Okay, then we have the sternothyroid, from the sternum to the thyroid cartilage, and above here we have the thyrohyoid cartilage. Okay, so these are the strap muscles. Okay, 1, 2, 3, 4. We also have one set on the other side, on the left side. So notice that the strap muscles are joined in the midline. There must be a fibrous tissue that glues them together. We call it the median raft. We just have to open them to reach the thyroid gland. Okay, so if we have to remove them, okay, yeah, so that's the strap muscles. So to remove them, okay, so that's the thyroid. Okay, this is the thyroid gland. It's a butterfly-shaped gland. We have the right thyroid, we have the left thyroid, and the thyroid tissue that joins them is called the isthmus. Okay, notice that the thyroid gland is not in the thyroid cartilage. So this is the hyoid, this is the thyroid cartilage, this is the cricoid cartilage, and this is the tracheal cartilage. So the thyroid gland is more related to the cricoid and the tracheal cartilage rather than the thyroid cartilage. Okay? Alright, so notice that where's the nerves that we have to find? Okay. Okay, so we need to find the recurrent laryngeal nerves. So these are the nerves that are found at the back of the thyroid. Okay, so if you have to trace that, it's just beneath the behind the thyroid gland. Okay, you have to trace that. You also have to look for the parathyroids. Okay, where's the parathyroids here? It's just at the back of the thyroid. So we'll type here parathyroids. So yeah, so if this is a thyroid gland, parathyroids, the superior parathyroids are here, inferior parathyroids are there. We also have on the right side parathyroid glands. Okay. We also have to find the carotid sheet. So at the lateral side of the thyroid gland, we have the carotid sheet. So this is the jugular vein and the carotid artery. Okay, right. And at the back of the jugular and the carotid sheet, we can find the vagus nerve. Okay, that's the vagus nerve. Okay. Now going back again to the thyroid. Okay, at the upper pole of the thyroid, we have a nerve there. We have the external branch of the superior laryngeal nerve. So we have to be careful not to sever that nerve so that the patient may be able to reach high notes after surgery. Okay, so that's the structure of the neck really. Now behind the thyroid gland, we have the trachea. Okay, the trachea. It's a U-shaped cartilage, no, joined by a smooth muscle at the back of it. Then we have the esophagus. Okay, so I really like this. Yeah, this is the esophagus, just at the back of the trachea. Okay, so it's quite far, especially if you just get the thyroid out. It's quite at the back. However, it's just you have to take note of the surrounding structures of the thyroid. Okay, so when we get the thyroid out, just close again the strap muscles and you'll be okay. Now we go up. This is the hyoid bone. These are the infrahyoid muscles. Above the hyoid bone are the suprahyoid muscles. So the suprahyoid muscles form the floor of the mouth. Okay, so okay. Yeah, so this is the floor of the mouth. This is the mylohyoid. Look, so it forms the floor of the mouth. Genohyoid. Okay, that's the genohyoid. Okay, also forms the floor of the mouth. We have the stylohyoid. Okay, aside. Okay, so notice that the majority of the floor of the mouth is formed by the mylohyoid muscle, and we have the digastrix. No, yes, digastrix. We have the anterior belly. It has a tendinous attachment to the hyoid bone. So notice that all of the suprahyoid muscles, the biggest one and the most that forms the floor of the mouth is the mylohyoid muscle. Okay, so yeah, more or less we have discussed all the muscles in the neck. No? Now let's go back to our lecture. So we have removed the thyroid. We have separated it from surrounding structures. We have to take all the lymph nodes out because back in our patient, uh, he has multiple lymph nodes. Neck dissection is the procedure wherein we remove lymph nodes from sides of the neck which cancer cells may have migrated. Typically, a papillary thyroid carcinoma spreads to lymph nodes of the neck. That's why we have to know the lymph nodes of the neck. So again, in this picture, we have the thyroid cancer and spreads to the lymph nodes of the neck. So lymph nodes of the neck are structures wherein the neck has abundant of. It looks something like this one. I usually teach lymph nodes. I usually describe the lymph nodes as like beans, like pork in beans. Okay, these are scattered all over the neck. The functions of the lymph nodes on the neck are, this is part of the lymphatic system. It filtrates, it has immunity functions, it has filtration functions. Cancers can spread through these lymph channels and gets trapped into these lymph nodes. So as we can see in our patient, the patient has enlarged lymph nodes, primarily because the cancer of the thyroid has already spread into these lymph nodes. The lymph nodes in the neck are organized according to levels. So of course, these levels will, like this one, we have different levels. So these levels will enable doctors to describe better the location of lymph nodes. Of course, we have to precisely know where the lymph nodes are located. Otherwise, it's very impossible because there's so many lymph nodes in the neck. So we have 7 levels of lymph nodes in the neck. Okay, so the lymph node levels are the following. So we have the level 1, level 2, 3, and 4, level 5, level 6. So in this diagram, you will see different levels. So it may seem daunting at first, especially to memorize the lymph node levels. But if you take note of our discussions earlier, this may be simple, may be really simple as you might think. No? So first, you need to know that the level 2, 3, and 4 are within the sternocleidomastoid muscle. That's it. As long as it is within the sternocleidomastoid muscle, this belongs to level 2, 3, and 4. So, if you notice in this picture, we have 2, 3, and 4. So, how do you know if it's 2, if it's 3, or it's just 4? So, you need to know important horizontal lines. So, we have 2 horizontal lines. So, first is the hyoid bone. We already discussed that in the previous slides. And next is the cricoid. We also discussed that in the previous slides. So if you bisect the sternocleidomastoid muscle into 3 parts, that's the 2, the 3, and the 4. Okay? So if you have lymph nodes found in this upper level, you report that as level 2. You have level 3 and level 4. Okay? Now, that is how simple to remember level 2, 3, and 4. Level 5 is in the posterior neck. So we have discussed earlier with the case of the 22-year-old female, anything that is at the back of the SCM is the posterior neck. So anything at the back of the SCM, if you have lymph nodes there, they are called level 5 lymph nodes. Okay? And level 6 is in front of the SCM, but below the hyoid. Okay? This is the hyoid. Below it and in front of the SCM is all level 6 lymph nodes. Okay? That's how easy it is. Then level 1 is above the hyoid. Okay? In front of the SCM and above the hyoid, and in front of the digastric muscles. We already discussed digastric muscles earlier. So this is the digastric muscle. It's a suprahyoid muscle, and it has an anterior belly and posterior belly. Anything in front of any digastric muscle is level 1. Okay, so 1, 2, 3, 4, 5, and 6. So that's how we report lymph node levels. So here we go back to our patient. So a patient has a big thyroid tumor. So there's usually where the thyroid is found. And notice you have here a lymph node and another lymph node here. So this is the hyoid, and this is the sternum. It's the mastoid, sternocleidomastoid. So probably this is probably level 3. Right, this is the guide. Okay, so these are actual lymph nodes in a patient. So yeah, this is 1A, 1B, 2, 2, 3, and 4. Okay, so you've done now with your total thyroidectomy and neck dissection, and it is so draining. Sometimes surgeons sleep on the floor. Yeah, around 7 p.m. you finished surgery, waited for the patient to wake up, and before heading home, passed by McDonald's to have a quick dinner. Okay, McDonald's. But you witnessed someone choking after eating some chicken nuggets. And you remembered you have a tracheostomy set in your car. So a tracheostomy set is a set of instruments you use for a tracheostomy procedure, wherein you put a tube into the neck so that a patient will be able to breathe if she or he has upper airway obstruction. So this is an example of the tracheostomy set. We have, of course, the instruments, and we have the tracheostomy tube and all those instruments that you need. So we'll talk a little bit about emergency tracheostomy. It is found in your ILOs. So whenever a person has an upper airway obstruction just like this one, normally we breathe to the nose, goes down into the larynx and into the trachea and then into the lungs. But whenever a person chokes or there is an obstruction above the trachea, then we call it upper airway obstruction. And an emergency tracheostomy will have a bypass, and the patient may be able to breathe even though there is an obstruction. So you might notice that in patients with choking, or patients with tumors of the upper airway. So here the patient breathes to the tube and goes downward. So that's an emergency tracheostomy. In order to do the emergency tracheostomy, you just have to know the trachea. For this slide, we already discussed, strap muscles, thyroid, and the trachea. So to do emergency tracheostomy, you just have to review the structures before the trachea, including the thyroid. Again, we'll review skin, platysma, strap muscles, left and right. You open it up, you will see the thyroid. And sometimes you see the trachea underneath. So you can actually do that emergency tracheostomy here, just below the thyroid. Again, as a review, skin, platysma, very thin layer, then the strap muscles, then the thyroid, and the trachea. You just have to bypass that, and you'll be able to do a tracheostomy. So this is the procedure of tracheostomy. You incise the skin. Once the skin is opened, you see the strap muscles. Again, open it like a curtain. You'll see the thyroid. Sometimes you have to open the thyroid, or sometimes just put a slit below the thyroid in the trachea. Then the patient may be able to breathe. Okay, so this serves as a review of our anatomy earlier. Typically, we put the tracheostomy tube between the second and third tracheal rings. Again, as a review, this is the hyoid bone, this is the thyroid cartilage, the cricoid cartilage, and the tracheal cartilage. You do the tracheostomy in the tracheal rings, not in the cricoid, not in the thyroid cartilage. So, back to the story. Fortunately, you know how to do Heimlich maneuver. You give 5 back blows and also 5 abdominal thrusts, and the patient was able to spit out the foreign body and able to breathe. So you don't need to do the emergency tracheostomy. So you are able to sleep good. Thank you. I'll be uploading this video, and you can always review on that. Hopefully, I made anatomy in the face, in the neck, and also some structures in the neck easier for you. And yeah, also you have the resources in the internet. You have to read on that. And again, thank you for listening, and stay safe. And yeah, we are in this together. Thank you.